everybody. I hope you're enjoying the lunch. Let's go ahead and get started. Today we're going to be talking about hypertrophic cardiomyopathy. In particular, our topic today is really taking a step forward in HCM precision medication to align our clinical and managed care approaches with new guidelines, long-term evidence, and real-world experience, in particular as it relates to cardiac myosin inhibitors. So I'm very happy today to be standing up here with Dr. Florian Rader. He is a physician from the Cedars-Sinai Medical Center in Los Angeles, California. He's highly involved in a lot of the cardiac myosin inhibitor trials, and I just want to say he's an overall awesome guy.
Thank you.
And so my name is Andrew Willeford. I'm an assistant professor at UC San Diego's School of Pharmacy. My clinical practice is in heart failure and hypertrophic cardiomyopathy, as well as my research. Full disclaimer, I am indeed 36 years old. Last year I did this, somebody came up and told me I look like I'm 16. So I grew out a little bit of a stubble to try to make myself look a little bit older. So just welcome everybody. I'm gonna say thank you to PeerView for the symposium and Bristol Myers Squibb for the educational grant for this symposium. If you haven't already, take the pre-event survey. As a reminder, look out for additional polling questions throughout the presentation. We'll do kind of pre-post test kind of style questions. Submit your questions online, and we'll answer them at the end in our Q&A session. And you'll be able to submit through a QR code, which we'll show in a moment. For those of you in the room, use that QR code. For those of you online, just respond to polls on your screen and enter questions in your chat window. So another great thing we have for you is scan this QR code. It is a $50 incentive prize for you to ask your questions and submit your answers. The more you do, the higher chances of winning. At the very end, check your app, and if you're a healthcare professional and you see a green winner, that means you won. All of our materials are available online as well. And for the sake of time, I mean, these are our goals for today, but for the sake of time, let's get right into it because we do have a lot of information to go through. So I'll hand it off to Dr. Florian Rader.
Perfect. Thank you so much, Andrew, for the nice introduction. And it's a real pleasure to be here. Full disclosure, this is the first time I speak at a pharmacist meeting, so I'm very excited to be here. I work with a clinical pharmacist in clinical practice. I think the collaboration between physicians and pharmacists is so important and ever growing, so I'm really excited to be here. And we're talking about hypertrophic cardiomyopathy. 3 years ago, it probably wouldn't have had a huge impact if I gave the same talk at this meeting because we did not have any specific treatment options then. Now we have specific treatment options. We actually have clinical trial supported medications that now are really very involved when it comes to how much the pharmacist has to think about these things. So I think it's perfect timing for this talk, so let's go right into it. So what's hypertrophic cardiomyopathy? It's essentially thickening of the left ventricle. So as the name suggests, there's thickening of the ventricle, and it's typically from a genetic disease, a genetic problem. So it shouldn't be in the setting of uncontrolled high blood pressure for decades. It shouldn't be in the setting of severe aortic stenosis. It's unexplained thickening. And it is the most common inherited cardiomyopathy. There's certain genes that we can attribute to this disease and that we can actually detect. The symptoms are very sort of nonspecific. People get some shortness of breath. They're not exercising very well. They get chest heaviness, palpitations, and therefore I think that's the big problem about HCM. The symptoms are so nonspecific that these patients oftentimes remain undiagnosed for many, many years. There is a little bit of a scary part of HCM because it is a potential cause of sudden cardiac death and dangerous arrhythmias plus atrial fibrillation. So it's really important to detect these patients and treat them appropriately. And as I mentioned, undertreatment is really the problem here and underdiagnosis. So if we look at population-based studies, the prevalence is probably anywhere between 1 in 200 and 1 in 500. If you look at genetic studies, the prevalence of the gene that causes HCM is actually about 1 in 150 or so, but the penetrance of this disease is less than 100%. So only about half of the patients who have the gene abnormality actually develop hypertrophic cardiomyopathy. So if you apply this prevalence to the United States population, for example, you would think that we should have probably around 1 million HCM patients in this country, but yet from claims data, we only have about 100,000 that seem to carry the right diagnosis. So underdiagnosis is an issue, and there's some disparities when it comes to sex, race, and age. And of course, talks like this will hopefully help fight these disparities and make everybody more aware of this problem. So this is how HCM looks like. To the left, you can see a normal heart. This is the left ventricle, and you can see that the walls of the left ventricle are normal thickness. And then you can go down a sort of progressive or sometimes non-progressive line of variation of this disease. So there is some hypertrophy that where the thickening of the heart does not seem to be in the way of cardiac outflow, which is right here. Then there's the obstructive form where the septum is so thick that it's just in the way of the heart, squeezing blood out of the heart. So this is definitely obstruction of the level of the left ventricular outflow tract. Then there's this form where the obstruction is more in the middle of the left ventricle. These forms oftentimes develop over time an apical aneurysm, which is a problem by itself when it comes to arrhythmic problems. And then there's the apical form. This is typically non-obstructive and oftentimes missed because the echocardiograms that have often like a near field problem with detecting this thickness. So this is sort of the variation of hypertrophic cardiomyopathy. What we're talking about with cardiac myosin inhibitors is mostly affecting this variant. Okay, and this just kind of goes through it. So again, on the symptoms, most patients will describe shortness of breath, and I think these estimates are probably a little bit on the low side, I would say. I would say more than half of patients definitely are symptomatic when it comes to HCM of any form. When it comes to obstructive HCM, I would say way more than 50%. Exercise intolerance, in my experience, is also above 50%, I would say. Some slight limitations. Patients clearly adjust their lifestyle to their symptoms, and maybe they just don't exercise as much, and then they think they're okay, but they're really not. Lightheadedness, arrhythmias, and chest pressure are also very commonly described. And here are the treatment options. So the scary part, sudden cardiac death, we're not going to talk about this. There's certain risk factors that increase sudden cardiac death and make physicians that treat these patients decide whether or not patients need defibrillators. We'll kind of skip over that. Symptomatic left ventricular outflow tract obstruction is really the main goal of treatment in obstructive HCM. And the treatment algorithm, according to the guidelines, lists beta blockers first. So most of the times people prescribe metoprolol, and you will see that in clinical practice. Second line would be non-DHP calcium channel blockers, so verapamil or diltiazem. Disopyramide, septal myectomy, or alcohol ablation was previously sort of listed on one level of treatment. And in previous iterations of guidelines, there were no cardiac myosin inhibitors, and now they're just being introduced into the new guidelines. Sometimes the ejection fraction drops in HCM, so you have advanced heart failure, and the rules are essentially the same, like heart failure with reduced ejection fraction of any cause. And then once atrial fibrillation shows up in HCM, it's a really important thing to detect that because the stroke rate is just so high and there's no CHADS-VASc risk scores. Everybody who has atrial fibrillation and HCM needs to be on an anticoagulant. So very important considerations here. The important thing to sort of underscore here is that any of these treatment options that we've used for now probably 7 decades or so are not supported by any clinical trials. There hasn't been a single randomized trials for any of this stuff. So sort of empiric treatment, expert opinion. Then the cardiac myosin inhibitors, they were FDA approved now about 2 years ago. They're really the first therapy that's been tested in adequately powered clinical randomized trials, and we'll talk about the results of these trials. It's always good to kind of have a little bit of a case that we can think about to make it a little bit more realistic. So here we have Tina. So Tina is 48 years old. She has shortness of breath, she has palpitations, she has chest discomfort, all the typical symptoms of HCM, but she also has hypertension, which is a little bit of a red herring here, I think. And she is actually on 2 pretty potent antihypertensive medications, irbesartan and amlodipine. And on the EKG, she has LVH with repolarization abnormalities. So a lot of doctors would probably chuck this off as, oh, it's just hypertensive heart disease. And she probably would not get the right diagnosis in a lot of cardiology practices. She does meet the definitions of HCM, so her septum is greater than 15 millimeters, and she actually has outflow tract obstruction. All right, so looking at all this, again, here's her treatment, and whoever sees this patient, they actually read the guidelines. They started Tina on metoprolol, which is the right thing to do. No question, you should try it. However, if you look at the clinical data of metoprolol in obstructive HCM, you will see that about 90% of patients on metoprolol will have some residual gradient, so some residual obstruction, and almost everybody remains at least class 2, so nobody loses their symptoms and becomes New York Heart Association class 1. Okay, so starting her on beta blockers, and I'm looking forward a little bit. Spoiler alert, her symptoms probably will persist. And then you go down the algorithm, and then you could send her for surgery, so septal reduction therapy, which is open heart surgery. You slice out the thickened part of your septum. Pretty brutal surgery with, recovery that's not very easy, I would say. But you can also consider disopyramide, which is a class 1 antiarrhythmic. It does have negatively inotrope properties, and that's why it works. It's been studied, but it's only been studied in non-randomized trials, large observational. When I say large, it's about 100 patients or so in that study. So it's currently ranked in the guidelines on par with cardiac myosin inhibitors, which I think is a little bit unfair because cardiac myosin inhibitors, out of these 3 treatment options, actually have a randomized trial. But anyway, this is the algorithm. It may change over time. We'll see. So this whole concept of shared decision-making in HCM is really important. It becomes more important in any aspect of medical treatments, I think. But it is important to kind of discuss the patients. What are the treatment options? One, do you want to be genetically tested? Do you want to know whether or not you have a genetic problem going on? And do you then want to know whether your children have the same problem? I would highly recommend it, but some patients may say, I'd rather not know, and they're worried about insurance implications and things like that. You have to discuss with your patients whether or not they want defibrillators. Some patients want absolutely be 100% safe, but you have to recognize that most patients who receive a defibrillator will never use it, so there's also problems with defibrillators. And then finally, obviously, it's important to discuss what are the therapy options, surgery, disopyramide, or cardiac myosin inhibitors to kind of come up with the right solution for the patient. All right. So when it comes to septal reduction therapy, so it's clear that the surgery works, right? You slice out that thickened part of the left ventricle, you get rid of the obstruction. Patients, after a difficult recovery most of the time, will feel better, no doubt about it. However, if you look at consecutive myectomies without death, that's a terribly scary way to put it. So if you send your patients to a surgical center at a low volume, just imagine, you send 7 patients to that surgery at that hospital, and every 6th patient of those 7 dies. What a terrible outlook. Like, I would never do that, right? And I don't think patients would sign up for that. And even in middle or high volume hospitals, the mortality rate is actually not negligible. And fact is that 70% of surgeries, surgical myectomies, are done in these centers. And of course, you can send your patient to Mayo Clinic, Cleveland Clinic, and large surgical centers. Then the outcomes are dramatically improved, and death rates are really low. But reality is that most patients are unfortunately getting treated in these lower volume centers. There's some data that would suggest that if you compare surgical myectomy, SM, in these centers. Overall, the mortality rate is pretty good if you compare to alcohol septal ablation, which is a catheter-based procedure to also shrink down that thickened septum. Probably won't go into the details of this procedure. The outcomes are probably fairly similar. And as I mentioned, either of these procedures are done in low-volume centers. Okay, so here we have now a little bit of a question before I get into the whole topic of cardiac myosin inhibitors. So if you want, you can scan this. Again, you can win $50. And then think about this question. So septal reduction therapy for HCM is required for any patients with obstructive HCM who remain symptomatic because there's just nothing else out there. It's shown superiority to disopyramide in a head-to-head trial, or it has better outcomes when performed in high-volume centers, and it must be attempted before a patient can qualify for CMIs. Or I'm not sure, and that's totally fine. I'll tell you about it. Okay, so you're doing great, you're doing great. Very good. So I think this is the best possible outcome of this question. Nobody thinks people have to go to surgery before they qualify for a CMI, so that's great. And indeed, of course, a high volume center, patients will do much better there. So perfect. I think we can go on with this. Yeah, let's move forward in the interest of time. So good job, and I'll explain everything to those who are not sure. Can you forward the slides? Yeah, okay. All right, let's go back to Tina. So she's on irbesartan, amlodipine, metoprolol was started. She was obstructive. Interesting, she has a family history of a nephew who also underwent septal reduction therapy for his obstructive HCM. So there clearly seems to be a family history and a genetic component of this. However, her nephew had a stroke during or right after the surgery, which is not common, but also it unfortunately does happen. So Tina absolutely does not want any invasive procedure and wants to know more about medication use. So here's sort of the march of science when it comes for medication treatment of obstructive HCM. You started in the 60s and 70s with beta blockers. The first tiny randomized trial for metoprolol in OHCM actually was in 2021. Back in the 1970s, they first tested calcium channel blockers, then disopyramide in the 2000s, and then in 2020 you had EHA-ACC HCM guidelines that obviously did not include CMIs yet, but they proposed treatment algorithms, and in 2022 mavacamten was FDA approved. And now it did enter EHA-ACC guidelines, and a little bit before that ESC guidelines. The ESC guidelines I would sort of completely ignore, to be honest, because they list actually CMIs as a class 2B indication, because nobody in Europe at the time these guidelines were written has used mavacamten in clinical practice. So it was just the lack of experience that led to those guidelines. So perfect. So I think everybody would agree she may benefit from a CMI. So she wants to know more about this class of medication. So let's talk about CMIs. So it's the first FDA-approved treatment option for symptomatic obstructive HCM. It is really designed to optimize symptoms in patients with at least class 2 or class 3 symptoms. So you could argue patients who have a very high gradient, really severe obstruction, but simply no symptoms, which I think is rare, to be honest, but you could say this is maybe not indicated. Class 4 hasn't really been studied in that population, although we did see there was the VALA trial, which included class 4, but that's not included in the label. So, we'll discuss that. In my book, I think it would be reasonable to start even patients with very severe class 4 symptoms. You see the half-life is 6 to 9 days. We're not going to talk that much about aficamten, but that's a cardiac myosin inhibitor, which is still investigational, not FDA approved. However, all the trials have succeeded and they were successful. So most likely this will get FDA approval very soon, if not at the end of this year, but probably early next year. So it's good to hear a little bit about that other medication. So how mavacamten works is it affects the myosin head, so the contractile elements of the heart, essentially of the heart muscle, has these actin filaments and then the myosin heads. Myosin connect with actin, and then the interaction between these two proteins, they slide against each other, and that's the motion of the cardiac muscle. In a normal heart, most of these myosin heads are sort of in a relaxed state. They don't want to contract, they don't want to adhere to actin, they're just sort of lazy and sitting back. In HCM, it's different. In HCM, most of these myosin heads are actually all the time wanting to contract, and that's why the contraction in obstructive HCM is very hyperdynamic. The ejection fractions are not 55, 65%, they're oftentimes 75%. So even when they sit on the couch, watch TV, the heart's just pumping away like crazy. And what mavacamten does, it affects the way these myosin heads are in a more relaxed state, and thereby the contractions are decreasing. So it's a negative inotrope, obviously also a negative lucitrope, so the heart muscle also relaxes easier after contraction. And aficamten works, let's just say, in a very similar way overall. All right, I guess here's a reminder that scan this, you can ask any question, and you might win $50. Okay, so mavacamten. So the original study that led to FDA approval was the Explorer HCM trial, which we will kind of gloss over now because it actually had an extension trial, the Explorer LTE or MAVA LTE trial, which just followed these patients over a longer time point. And I was able to publish these data just last year. And how it happened, and there you can also see kind of the dosing scheme of mavacamten. Everybody gets started on 5 milligrams. And then after 4 weeks, they're eligible, at least in the trial, of either down reducing the dose if the obstruction is already gone. So you always want to use the minimal effective dose of mavacamten to increase safety overall. And then in the trial, they were able to adjust medication dose in 4-week intervals. In clinical practice, that dosing scheme looks slightly different, and I think Andrew will talk a little bit more about that. But anyway, in this trial, patients then, they ended up on the right dose, and then they were followed out to overall at least 5 years. These studies will probably extend to even longer time points. And you can see we measured along the way heart failure markers, of course, frequent echocardiograms as a safety check, and evaluated and asked patients how they felt. You can see the effect of mavacamten clearly does reduce ejection fraction. That's by design, that's how it works. So even with the 5 milligram dose initially, you see a drop in ejection fraction pretty quickly, and that sort of levels out, but continues to drop as more and more patients find their optimal dose over time. And here we have follow-up all the way up to 84 weeks, so it's a fairly decent follow-up, I think, for a completely new medication class. And you can see at baseline, most patients were class 2. There were a few that were class 3, so really severe symptoms in this case. And after 12 weeks, half of those patients were without symptoms. After 48 weeks, this proportion even increased further. And along the way, a lot of patients didn't only improve their New York Heart Association class by one, but also by 2 classes. And there's a very small proportion of patients who will remain symptomatic and they're not happy with mavacamten. But with any treatment, you don't have 100% treatment response. So that's not surprising. This is actually the measure on echocardiography that we follow. So it's a Valsalva gradient. So you can measure flow acceleration or the velocity in the outflow tract in the heart, and that would be the resting gradient. And then you just make the patient bear down really strongly, kind of like sitting at the toilet. And by that, you reduce the filling of the left heart. Left heart shrinks down a little bit, and the gradient increases. And you could say, why do you do that? It's kind of an unnatural way of assessing, a hemodynamic problem in the heart, but it actually represents of how the heart responds and how the obstruction responds during exercise. So it's sort of just mimicking exercise on a resting echocardiogram. You can see that this gradient, this degree of obstruction, drops down after 4 weeks already dramatically and then keeps on improving over the course as everybody in the trial gets optimized. And then we asked patients about their patient-reported outcomes, so KCCQ, heart failure questionnaire. And in terms of improvement, these are like all different kind of heart failure trials here. So these are CRT trials, trials of MRAs, SGLT2 inhibitors. So it's really here on the upper end of how dramatic the improvement of patient-reported outcomes was. Not quite as dramatic as aortic valve replacement trials in severe aortic stenosis. These are really, you just can't accomplish that with any medication, but really important, clinically important improvements. So this was Explorer, sort of all-comers obstructive HCM. And then we did VALOR HCM. This study looked at something different. So you have obstructive patients. They already met their surgeon or their interventional cardiologist, so they were ready to have an invasive procedure to reduce that obstruction. But then we said, no, hold on. Let's randomize these patients and see if mavacamten can make them ineligible for this invasive therapy. So 1-to-1 randomization. Mavacamten was titrated as an Explorer pretty much, and then at 20, at 24, 28 weeks and so forth. And then we looked at the primary outcome, which was actually 16 weeks, and then also at 32 weeks and 56 weeks in an extension study, how many patients still needed invasive therapies, including surgery. And there you can see, of course, at the beginning of the trial, everybody was eligible for open heart surgery or alcohol septal ablation. Then after 16 weeks, only 18% were eligible. At 32 weeks, only 11, and at 56, only 9. And then, because it was just a nice thing to do, we let patients who were randomized to placebo, we let them cross over and also get the benefit of cardiac myosin inhibitors. And then they sort of trailed a little bit, but also their eligibility shrunk down to about 14 or 19%. So you can really avoid the need for invasive therapies with this medication, which is really very cool, I think. In terms of improvement of New York Heart Association class, the vast majority was improved by at least one class, and many of those by 2 classes. And these patients were a little bit sicker than in Explorer. They were New York Heart Association class 3 or 4, so much more severe symptoms at baseline, and their improvement was also more dramatic in the trial. KCCQ improved dramatically in a lot of patients here. You even have some patients who responded sort of in the TAVR, aortic valve replacement amount in terms of improvement of KCCQ, but on average, the majority had reported improvements. When it comes to safety, ejection fraction, again, drops off, right? And that's what we're worried about. I'm not terribly worried about it, but that's what the FDA was worried about, is that some of these patients may just drop their ejection fraction, develop systolic heart failure, and do poorly. So in terms of how many patients had this complication, overall 12 patients out of 108 here in the longer-term extension dropped the ejection fraction. So this ends up at about 11%, I think, in clinical practice. Now, seeing this medication being used, I think that's a maybe slightly high to sort of expected result. But if you look at who had severe heart failure, so less than 30%, this was really a very small number. And most of these patients actually are asymptomatic. I had personally 4 patients who dropped their ejection fraction below 50, and that's the cutoff where you have to change medication dose, and none of they actually had worsening symptoms. They all were kind of surprised, like, why do I have to interrupt the medication now? But, it's a safety. And then you repeat the echo 4 weeks later, and the ejection fraction is back up. And then Dr. Desai from Cleveland Clinic published this study on real-world outcomes. So this is not a randomized trial. This is just looking at 150 patients who are being prescribed mavacamten. The average age was slightly higher than in the original parent studies. Almost all of them were on beta blockers, and a large amount of patients were actually class 3, and that's probably because Cleveland Clinic is a referral center for septomyectomy, so they get sicker patients overall. They went through the treatment algorithms, and then they looked at 12 weeks, what are the real sort of real-world outcomes. And you can see most patients ended up on 5 milligrams, a portion on 10, and some patients were even okay with the lowest dose of 2.5 milligrams. Overall improvement in New York Heart Association class was comparable, I think, to the parent studies. Overall ejection fraction dropped as expected by less than 10%. Resting gradients, Valsalva gradients dropped down, so most patients actually went below the threshold of being obstructive, which is 30 millimeter mercury. And overall, about half of patients reported at least one New York Heart Association class improvement. Yeah, and then briefly about aficamten. Are you taking that on? Okay,
Yep.
Okay. So I'm going to hand it off over to Andrew now, and he will discuss a little bit this newer class of.
So we have aficamten. It actually has a PDUFA date of September of this year, 2025. And so it's an investigational drug. NDA was submitted back in Q3 of 2024. And so we'll go over a little bit of the data here. So its phase 3 clinical trial is called Sequoia. It came out sometime mid-2024. I think it was maybe May is when it was published. And this was a phase 3 trial, placebo-controlled. It was about 282 individuals with obstructive HCM, half to AFI, half to placebo, and then followed for a short term of 24 weeks. Baseline measurements from echocardiography showed about 55 millimeter mercury LVOT gradient with an EF of about 75%. When looking at their primary outcome, which was peak oxygen uptake, which is, by the way, you measure that when you do a cardiopulmonary exercise test, and what's clinically meaningful of a change would be 1. That's what's the consideration for what's clinically meaningful. When you compare AFI to placebo, the least squared mean difference is 1.7, and that's statistically significant. So this is demonstrating some increase in functional capacity for patients who are randomized to AFI versus placebo. When we look at secondary endpoints, pretty similar kind of story. Aficamten was better. And for adverse events, similar at least statistically, and we'll show you what that is in a moment. So for a nice secondary outpoint that we kind of talked about with regards to mavacamten, it was the KCCQ, or Kansas City Cardiomyopathy Questionnaire. Just a little bit of insight about it. What's minimally clinically meaningful is an increase of 5 points. So what you see here on the left in the line graph is the difference between AFI and placebo is 7.9, statistically significant, meets that threshold of greater than 5. If we go over to the right in the bar graph, we can kind of see the categorization of the increase in the score. For small, it's 5 to 10 points. Moderate is 10 to 15. Large is 15 to 20. And then very large is greater than 20 points. Most of that score in KCCQ is driven to significance by an increase in the very large improvement category. If you actually calculate a number needed to treat for this, it's actually 6. So you got to treat 6 patients with aficamten in order to get a very large improvement in their quality of life symptom score. So it's pretty impressive with regards to those values. For the safety parameters, overall statistically, really not much of a difference. For patients with kind of treatment emergent serious adverse cardiac events, really not much of a difference between placebo and aficamten. If we look at common adverse events that were greater than or equal to 5% in kind of incidence, not much of a difference other than numerically a higher rate of hypertension in the AFI group. So hypertension about 7.7% and then 2.1% in the placebo group, but still overall not much a difference in adverse events in this 24-week trial. Importantly, however, we do have at the bottom line, there were 5 patients, or about 3.5% of the AFI population, that had a reduction in EF to less than 50%. But none of them actually had to interrupt treatment. They actually just had to do dose reduction, and then their EF went back up. And none of them had a heart failure exacerbation as well. So we've talked about kind of the basic phase 3 trial for Sequoia for aficamten. Now we'll talk a little bit more about just the long-term safety of all of our cardiac myosin inhibitors we've talked about. So mavacamten, even extending beyond Dr. Rader's study, we have now 180-week data. And this is still from that same cohort from MAVA LTE. They have about 166 weeks of median follow-up. For the mean EF decrease, it was on the order of about 10% from baseline to 180 weeks. About 8.7% of that population actually had their EF decrease to less than 50%, which again was reversible after holding therapy, which we do in clinical practice as well. And so about 78% improved by at least one NYHA class, and there were 5 deaths that were adjudicated to be unrelated to mavacamten therapy, and there were 18 patients with new onset AFib. For aficamten, because it's so new, we don't really have awesome extension data yet, but there was a nice pooled analysis from Dr. Ahmad Masri that was presented as an abstract at ESC in 2024, but they found about 205 patient years of follow-up for patients pooled from Forest HCM, which is the long-term extension for all the AFI patients. And they pooled that with Redwood and Sequoia data. About 3.9% of patients had an EF drop to less than 50%. 6 patients did discontinue treatment early, but it was unrelated to aficamten. And no deaths were found with 5 patients with also having new onset AFib. So this is really the best kind of long-term data we have so far. So here's that question. Go ahead and answer that. Scan it. So is which of these medication classes for obstructive HCM has the strongest support from randomized controlled trials? Is it class 1A antiarrhythmics, beta blockers, cardiac myosin inhibitors, or non-DHP calcium channel blockers? Yeah, so the answer is cardiac myosin inhibitors. It looks like everybody has kind of switched over to what we've just been talking about. So everything else on that list is really just based off of non-randomized data. So all right, moving back to Tina, our patient case. After consulting with the healthcare team, including cardiologists, pharmacists, patients deemed a candidate for mavacamten, but what needs to happen next for this patient? It's not as easy just to say, all right, here's your medication and go off and live your life. It's really important to have everybody get on the same page with regards to managing this medication because there's a lot of follow-up and requirements tied to it. So some of the barriers to use of cardiac myosin inhibitors, in particular as it relates to mavacamten, include access to care or just access to getting the medication in general, the cost of the medication, coordination of follow-ups in the echocardiograms from the REMS program. Specific drug interactions are of importance, and even pregnancy. So mavacamten does have some animal studies that demonstrate fetal toxicity, so it's very important to have patients who have childbearing potential to be on effective contraception. And what's also important to note is that mavacamten induces CYP3A4, so a lot of our contraceptions are 3A4 substrates, so you end up having to actually talk about non-hormonal contraception measures in order to help protect any kind of issue with regards to fetal toxicity. So I always like to think about it when I'm approaching my patients who are referred to me to help get mavacamten on board for is, what's the best for you? What is the best that's going to be conducive with your lifestyle? There are a lot of requirements for this that you have to abide by in order to get this medication, but it does have a lot of potential to help you. And so looking for those solutions is extremely important to have a discussion with the patient about. And so one of the kind of issues, or I should say, potential barrier for patients is the REMS program. While I think it's a very good program to have, it helps us make sure we're doing the right thing for the patient, it can become a bit of a burden for patients because it's pretty strict. So what you look for in the REMS program is for systolic dysfunction from mavacamten, and you have to have your patient come in and get regularly scheduled echocardiograms to check for that ejection fraction. You don't initiate this therapy if their EF at baseline is less than 55%, and then you have to stop therapy, hold, wait 4 weeks, get a follow-up echo if their EF drops to less than 50%. There's also specific drug interactions, given mavacamten is a 3A4 and 2C19 substrate. So we have to be aware of specific medications to avoid using, and there's other specific medications that will elicit a need for a dose reduction in mavacamten by 1 level. So for example, they're on 5 milligrams, you go down to 2.5 milligrams. And so the part of the REMS program that deals with that is patients have to get their medication list checked before every single dispense from a specialty pharmacy. The clinicians, when they call the patient to talk about their echo, must do the same thing. While we do have these considerations for drug interactions, the real-world REMS data that I'll show you in a moment actually demonstrates a pretty low need for dose adjustment to mavacamten, or a pretty low need for kind of stopping other therapies. So the rate of drug interactions is actually pretty low in real world. And then last but not least, it's super important to just get everybody on the same page. So all clinicians that are going to be submitting information to the REMS program has to go through a brief training. I mean, we both did. We also need to make sure that the patient is fully aware of what this REMS program is for. The way I always pose it is it helps ensure we're doing the right thing for you. So this is a little snippet into what that REMS program looks like. Patients have to have a baseline echocardiogram, and then once they start taking therapy, they have to take it at 4 weeks, 8 weeks, 12 weeks. If you do a dose adjustment at 12 weeks, you have to come back, get an echo at 4 weeks. But once you get to a stable dose, you can go to every 3 months thereafter. So looking at this, you can think that, okay, mavacamten has good benefit towards kind of quality of life and improvement in symptoms based off of the data that Dr. Rader's talked about. But just looking at this graph or this chart, you can see that the imaging burden can be pretty substantial, which is why it's so important to talk about that up front with the patient to ensure that they will follow up. You can't get this medication if you do not follow up. We just simply can't prescribe. All right, go back and let's answer this question. What test is required by mavacamten's REMS program to assess safety and response to treatment? Is it cardiac MRI, echocardiography, exercise treadmill testing, or Holter monitoring, or you're still not sure? I wonder how many patients would take MAVA if you had to do an exercise treadmill test every month.
Or cardiac MRI every 4 weeks.
Yeah, and the answer is echocardiography. So all based off of those previous slides we just talked about. All right, so we've talked about echoes. With regards to drug interactions, I've alluded to a little bit about mavacamten is contraindicated for use with some specific P450 inhibitors and inducers. Moderate to strong 2C19 inhibitors or inducers, strong 3A4 inhibitors or moderate to strong 3A4 inducers. It's kind of a mouthful. There is a nice list of medications that you can look at and use as a resource, but whenever I train people in my clinic, I always tell them use all the resources and drug interaction checklists that we have available to us, because if you just have a list, there's always going to be more medications that could be added to it. So just always look it up when you're about to make a dose adjustment, start the medication, monitor the patient with every single echo. Just always look it up. So some good examples of prominent DDIs include like nirmatrelvir plus ritonavir for a COVID, strong inhibitor. Omeprazole is a weak 2C19 inhibitor, so you could just replace it with pantoprazole or an H2RA like famotidine. Fluconazole and other antifungals are 3A4 inhibitors and can cause issues, as well as amiodarone, which would actually elicit a need for a dose adjustment to your mavacamten. There's also clinical experience that suggests probable interaction with alcohol and marijuana. Alcohol is really through just the pathophysiology of the heart, just the structure. If you're an obstructive HCM, you drink a lot of alcohol, diuretic, you lose a lot of volume. Patients with obstructive HCM are typically preload sensitive and can't really tolerate low volume in their heart, and it causes symptoms. For marijuana, we know that it can cause some induction of some CYP enzymes and could potentially cause problems. So with regards to that real-world REMS data, what we have here published by Dr. Desai is 22-month follow-up from the REMS program. What we see in the purple are the number of patients enrolled into the program, about 5,500. Green is the number of patient status forms submitted, so like every month you submit a status form. And what we see is in this whole cohort of 5,500 patients, about 4.6% of patients actually had a reduced EF to less than 50%. So it's actually less than what we see in the clinical trials. With regards to individuals who are on therapy for greater than or equal to a year, so about 1,900 patients, it's even lower. It's about 4% of patients had a reduction in EF to less than 50%. With regards to our drug interaction checklist, this is what I was alluding to a little bit earlier. It's actually only about 2.5% of those checklists reported some kind of mavacamten dose reduction because of a drug interaction, and only about 0.32% reported some kind of discontinuation of the interacting medication. So drug interaction concern is actually a little bit less than maybe what we were expecting, but still important consideration and always to screen for. Now, with regards to our Valsalva left ventricular outflow tract gradient, again, that LVOT gradient is a nice readout of what potentially the patient's level of symptoms are. So if we can reduce your gradient to less than 20 or non-existent, that would theoretically help us indicate we're helping your symptoms. If you look at the data at baseline before starting, everybody's greater than 30. But as you get started on therapy and truck through 6 months, over half of the patients have their gradient reduced to less than 20 millimeters of mercury. So it appears, just based off of the echo parameters, to be working, and this is all from that REMS program. Now, with regards to the REMS program, drug interactions, all those considerations, we still need to talk about cost with patients. Super important. We don't really have much commercial data, at least that I know of, but this is a very nice demonstration of the cost out-of-pocket-wise for patients. This was published just this year in January, and these investigators took Q3 Medicare beneficiary or plans, about 4,600 plans. Only about 25% of those plans covered mavacamten. If you take those 25 plans and look at how they manage it, about 100% almost had mavacamten as a tier level 3 or higher. And then for prior authorization, almost all the plans required it, so about 94%, but no one required step therapy. For the yearly estimated out-of-pocket estimates for patients, like how much you paying for copay, $7,800 when it was first out, very high, but as you can see, it's come down now to $2,000 is estimated for today, and that's really just because of the Inflation Reduction Act. The $2,000 per year, while it is much better than $7,800, can still break the bank for some patients, so it's still quite expensive from an out-of-pocket cost perspective. So we've talked about cost, everything with regards to the REMS program. Other things that we always counsel about with our patients is how to recognize and respond to symptoms of heart failure. Also, we always hound the fact that they need to get their echocardiograms done and adhere to the REMS requirements in order to get the medication. I always stress that very hard. We do have patients who say, like, I just can't follow up, I don't want the medication. Like, understand, this is shared decision-making kind of conversation we have. And it's always important to inform the patient to inform us of any changes to their therapy. The way I always pose it to my patients is, I don't want you to worry about drug interactions. They exist, but just tell me every time you have a change, and then I'll worry about it and then tell you what to do and what needs to happen. I don't want you to ever think like, oh, I can't take that because X, Y, and Z. Just call Andrew and ask me, is it okay? And then, as I alluded to a little bit earlier, the potential for fetal toxicity with mavacamten, so it's important to have effective contraception for people of childbearing potential. There is some nice information available through the manufacturer's patient website to help guide all this as well as a nurse navigator that the patient can call if they're looking for other information too. So with all of that in mind, I always tell my patients, this is a lot of info I'm telling you. Like, I know it is a lot of info, but I'm your resource for every single step through this. And the reason why I'm your resource is because we have a very nice multidisciplinary workflow at our clinic. This is actually the actual workflow that we use in my clinic. We just published this a little bit late in 2024. And it involves pharmacists, our cardiologists, our nurses, our echo coordinators. I always like to think of this template as a plug and play kind of situation where you just kind of take the name out and put someone in there to help with the management. But these are really the basic steps of what needs to happen to ensure that the patient gets the best care they possibly can. So a multidisciplinary workflow has worked very well, I think, in a lot of centers, and is something that I promote for everybody. So just some take-home messages. Obstructive HCM can limit patients' functional abilities and markedly reduce their quality of life. First-line non-selective medications like beta blockers. In particular, for beta blockers, you're looking for non-vasodilating beta blockers like metoprolol. Don't use carvedilol because of the vasodilating properties. Any kind of vasodilating property could theoretically make the patient feel a little bit worse. You can use non-DHP calcium channel blockers, but all of these together are insufficiently effective and potentially poorly tolerated for patients. Septal reduction therapy, while it's effective and safe, it really is best performed to be done at a high-volume institution, which we're kind of limited with those. Cardiac myosin inhibitors are the first disease-modifying therapy for obstructive HCM and are recommended as second-line therapy in US guidelines. Mavacamten is the one that we currently can use, came out in 2022, and it's available through a REMS program. Aficamten is investigational and has a PDUFA date of later this year in September, so still investigational, not available yet. Real-world experience with mavacamten has been overall quite positive, as we've shown, with regards to efficacy, safety, and tolerability, and outcomes are comparable, if not maybe better, than those in the clinical trials. But as I always like to say towards the end is, it's so important with regards to these medications to have a good shared decision-making conversation with our patients to choose what's best for them, given the kind of plethora of options we have available and all of the pros and cons of them. And that's why it's so important to discuss every single one of them. So with that, thank you, and we'll start answering some questions.
Okay. Good, great job staying on time. So we have a little bit less than 10 minutes for questions, and there's a lot of questions coming in, so everybody wants the $50. And I'm just going to start reading those questions now. Some of them are really excellent questions. So first, maybe I'll take that one, because it kind of pertains to a patient that I actually saw yesterday. Has mavacamten ever been studied in patients with subaortic stenosis to see if it can reduce gradient and halt aortic insufficiency progression? So what subaortic stenosis is patients have a membrane just below the aortic valve, so it's a fixed obstruction, a little bit different than the dynamic obstruction that you have from the thickening of the hypertrophy in HCM. So I would say if the obstruction is strictly caused by the membrane, by the subaortic membrane, then cardiac myosin inhibitors won't work. So the answer, not knowing the case exactly, would be no. It has not been studied, and it's probably not effective. But if there's a little bit of a contribution of a small membrane and otherwise normal obstructive physiology, then it may actually be reasonable to try. But it's a case-by-case situation. The next question would be, would you recommend genetic testing as a criteria for diagnosis of HCM? It is not, because about 50% of our patients will be gene negative. But it is super important for cascade testing of other family members to see if they're safe or if they're also at risk of developing HCM. So, but it's not part of the diagnosis itself. Maybe the next one is for Andrew, I think. So yeah. How long in clinical practice do cardiologists evaluate the first-line therapy before adding on other therapies, including CMI? So how long do patients wait before they think about more advanced therapies?
Yeah, I mean, this is a good question. I think it's very clinician specific. If we think about, I always like to think about this as, when is the earliest time point at which I should see any kind of benefit from trying like metoprolol, for example? If we think about the half-life of metoprolol, it's on the order of max 7 to 12 hours, like very short. And we can try to titrate up as high as we can get it. In the TEMPO trial that Dr. Rader kind of briefly talked about, very small, they got patients to 150 milligrams of metoprolol, and they did it over the course of about maybe 2 weeks, and then they looked at what was all of their NYHA class, KCCQ, et cetera, compared it to placebo. All they're really doing is they do it in 2 weeks because they know they can titrate super quick based off of the half-life of the drug. So theoretically, we could do the same thing. If we wanted to go just based off of pure like heart failure with reduced ejection fraction titration timeframes, we could say, all right, here's 25 milligrams of metoprolol, come back in a week or two, we'll increase it if we can, and then over the course of multiple weeks of increasing the dose to as high as possible, then we could ask, okay, how do you feel? If you don't feel great, all right, we know that hasn't done well for you, maybe we should consider the next line of therapy. And so that's kind of how the way that I would think about how long we could potentially evaluate first-line therapy before moving on to the next. And I always like to base it off of PK. I guess that's because I'm a pharmacist.
Yeah, exactly. But to be completely fair, we all know how lazy physicians are, and they don't like to titrate medications. They just sit on their patients not doing anything. That's why we need your help in titration clinics, right? So yes, I agree 100% otherwise. Let's see, maybe this one is interesting. So can you use any beta blocker or angiotensin receptor blocker? So vasodilating beta blockers are not so optimal because they can reduce afterload, which can also worsen obstruction. And angiotensin receptor blockers, not great. They also reduce afterload obstruction, and therefore afterload load and could cause a worsening of obstruction. However, they are my favorite antihypertensive medications because they have the biggest continuation rate and lowest discontinuation rate among antihypertensive medications. So once you get your patient to the non-obstructive phase with mavacamten, these medications are then on the table again, and you can actually treat their hypertension with really good blood pressure medication. So it's just a little side point. What else should we do here? Do most practicing cardiologists have any idea where high and low volume SRT centers are and proactively discuss that with their patient? They probably do know, but then it's convenience that the patient stays within their system. There's a little bit also of that conflict that cardiologists refer to a certain surgeon, so patients stay within the system, and that unfortunately doesn't give the patient the best outcome. So it's a problematic question, I think. Do you ask your patients about KCCQ?
I wish. That's been something I've been wanting to do. It's just the burden of having a full assessment survey with every appointment is pretty challenging.
Exactly. Yeah, same here. How do you evaluate contraceptive options for patients on mavacamten?
Yeah, so non-hormonal is essentially what we end up having to go towards. So intrauterine devices, barrier methods, et cetera. And it is a real problem. We have had patients who actually have gotten pregnant, and we had to stop mavacamten. Patient was fine, baby was fine, but we caught it early. So it's always been a really good reminder, like we have to have that conversation every single time because it can happen.
Yeah, great point. So what patient characteristics would shift your decision to pursue SRT, so septal reduction therapy, prior to starting a CMI for symptomatic patients on other HCM guideline therapies? So yeah, so if beta blockers don't work, if calcium channel blockers don't work, these are easy therapies, and the patient just does not want to sign up for this program of needing all these echocardiograms, or mavacamten might not be financially feasible, then yes, then you would consider patients for septal reduction therapy at any point, really. There's also the argument of, what if it's a really young patient? Do you want them really on this medication for 5 decades, 6 decades, or do you want to, quote unquote, fix them? And I get that point. The problem is oftentimes you send them to surgery and they're not fixed. Maybe they don't have obstruction anymore, but they still have symptoms because their heart's still not normal. You're only treating like an inch of their heart problem. And yes, they feel better initially, but oftentimes symptoms come back. So I think there's probably not a great, really honest answer to that question. And it's, again, I think a shared decision-making that you have to apply here. So Cytokinetics produces aficamten. What else? KCCQ we did. Thoughts on a single dose of fluconazole and mavacamten?
Probably fine, to tell you the truth. If you think about a single dose, it's going to have maybe an immediate inhibitory effect on the CYP enzymes, but it's such a moment in time in comparison to a chronic use of the medication. Is probably very, very likely not going to cause a problem. Single dose, I think personally that would be completely fine just based off of, typical PK drug interaction kind of stuff.
Yeah, so really good questions coming through here. Any pending trials with clinical endpoints versus surrogate endpoints? I think that's an important question. The answer is probably no, because all patients eventually who were randomized to placebo want to get the benefit of CMI, so all long-term extension studies lose their controls, unfortunately. So now we can't really compare outcomes anymore. We can just count of what's happening to these patients. So maybe at some point we do see safety outcomes that are hard endpoints, like heart failure admissions or even death that is attributable to these medications. But right now there's no comparative studies, unfortunately. In your experience, what % of patients would you not start a patient on a CMI due to drug interactions?
Yeah, I mean, in terms of giving an actual percent, I think it's kind of hard to calculate that in my head, but we have done this in particular, as we've told patients we probably shouldn't start a CMI for you. It is not many. A good example, though, is we had a patient who was on olaparib for their cancer, and it's a 3A4 substrate. Mavacamten is also, which we didn't talk about, a 3A4 inducer. At the time, this was right when mavacamten came out, and there was no clinical guidance in our drug interaction checkers of what to do, but I still wanted to look to check what is this. I was like, oral chemo, it's got to be some kind of CYP substrate. So we figured that out, and then we had the conversation. We're worried, okay, mavacamten could induce metabolism of your oral chemo, which can cause a relapse in your cancer. Patient was in remission. And so we had that conversation of, we don't know exactly what's the degree by which we can actually give you mavacamten and then hope that you don't have an issue. So we had that conversation. In my opinion, I was like, let's not do it. And so it was a heavy conversation of like, let's not do this. And we told the patient all together, as me, cardiologist, the oncologist, said we probably shouldn't give you this medication because I think your cancer is more important right now. So that's a real life experience, example of that.
Perfect, yeah. And so we're already over time. I think there was one question about the statement down here. I actually didn't see that presentation at ACC, so
I forgot about that one. So sorry about that. So the concern was the whole idea that it wasn't completely placebo effect in that slide is patients on placebo, their KCCQ after the 4-week washout didn't completely return to baseline. But aficamten did, which was really bizarre. And so the hypothesis behind why that's the case is because the placebo effect is only some percentage of what the KCCQ increased, but the actual remaining is because the patient was in a clinical trial. So they actually feel like they're getting a better quality of life because they get really good follow-up, really good conversation, communication from clinicians. And that's the whole hypothesis behind it. I forgot to mention that.
Perfect, yeah. And then really quick, what cardiac monitoring modality would you use to diagnose arrhythmias and why? So I usually use these stick monitors, the 14-day, I don't want to name any brands because there's a couple out there, but there's good 14-day monitoring devices that I usually do once a year. And then one more question, that would be the last one. With respect to fetal toxicity, any issues if the male partner is on mavacamten?
Oh, with regards to male, not actually sure. I actually don't know of any data or concern or recommendations.
Yeah. I think the official answer is probably no problem, but there's no data on that. Okay, I think with that, we'll close. Thank you, everyone, for your attention, and I hope you learned something. Thank you very much.
Oh, yeah. All right. Say it again, sorry.
Do we find out who won?
Oh yeah, be sure to complete and submit your post-test evaluation for credit. Download the slides and practice aids as well, and then watch the replay of this event in the next 24 hours and the online activity. I saw a green over there.
Bravo.
Thank you for joining.